all. I am Dr. Brinda Gujjar, working as an assistant professor in Farooq University, Ahmedabad Physiotherapy College. Welcome you all. I would like to introduce our guest speaker. He is Dr. Art Patel. He is owner and director of Setu Child Development Center. He has received Youngest Achiever Award in the field of pediatric disability by Dr. Sel BJP. He has also received Youth Icon Gujarat Award. He has received Divyang Sivarth Award, and he has been a youngest speaker in Good State Conference. He has organized very first pediatric rehab conference of Gujarat State and doing every year now. He has been speaker and faculty on Reconnection Cerebral Palsy Conference. He has also been a guest and speaker at National Pharma Conference. He has been resource person in conducting various pediatric therapy courses. Now he organizes physio event on World Physiotherapy Day every year, and he has done live TV shows as a youngest panelist. He has also conducted more than 15 series. Now I would like to hand over to sir. Please, sir.
Hello, am I audible?
Yes, sir, you are.
Okay. Very good afternoon, one and all, dear friends who are present over here. It is noon time. We people have spared your timing to go through some new techniques and new things which are coming in our practical way. Before I would like to start, I would like to thank Dr. Gaurav Patel sir, Farooq University, for inviting me and having me over here. I hope after the end of this session, whosoever are listening this will find some fruitful things out of this seminar. Before wasting time, let's get started with today's topic. The role of physiotherapist in NICU and PICU. As we all are aware, the term NICU and PICU, up to the age of 28 days, the child is considered as neonate. The most caring and most important and essential role of a physiotherapist we play in this scenario. After that age, child definitely considered in the PICU department. Now, as a physiotherapist, this is our general role. Whenever we are seeing any kind of ICU, rather it's a pediatric, it's a neonate, or it's an adult ICU. As a physiotherapist, what kind of role we people are playing in an ICU? Mainly, this is the three categories where we are playing our work. One is important and essential part is restoration of the respiratory system. Another is the rehabilitation part for the patients. And third one is prevention of deformity. Now, before starting further, I would like to say as a pediatric developmental therapist or pediatric neurotherapist, why I am much interested in NICU and PICU, because as you all have gone through so many patients, maybe in postings or clinical practice, we have seen so many patients who came and tell us about their story and history, that my child was admitted in this ICU, in NICU, suffering from any kind of accident, brain injury or any epilepsy. At the history, at the end, we all are aware that any child who is suffering from any kind of disability must or maybe have gone through any kind of the ICU administration. So if as a physiotherapist, we know our important role, which actually starts at very first stage of child's life. It's a neonatal age. Maybe there is a chance we can prevent so many kind of disabilities, or we can play a vital role to give prevention for this child. So in the respiratory system, definitely we are working for the secretion clearance, re-expansion and collapse lung reopening. Important role we are playing to maintain the VQ machine ratio and winning of the ventilator mechanism. In the rehabilitation part, we people in a PICU mainly we are working for the muscle strengthening, thoracic mobility, movement re-education, improvement and developmental stimulation. For the prevention of deformity, definitely we people are using passive movements, stretching, splitting and positioning. So this three kind of role we people are playing in the NICU and PICU. Now, what kind of topic we people are going to cover in today's session? It's introduction, indication, contraindications, some basic things, equipments, pre and post procedure assessment monitoring, complications, and documentations. As we all are aware, in the ICUs, the main role of a physiotherapist are as a chest physiotherapist, or we call it CPT. The role of a physiotherapy in a newborn infant is to increase the clearance of lung secretion to maintain the maximum lung expansion and to give child normal clear air ventilation pathway, so that we can sustainably, or we can reduce the chances of the hypoxic ischemic brain insult or injury. By doing this, we are working to reduce the need of the ventilator support for the children, improving oxygenation, prevention of endotracheal tube and obstructions, and by doing this, we can save child by the excessive brain insult injuries. We are having short-term and long-term goals as a NICU or neonatal therapist in the ICUs. The short-term can be removal of obstruction of the secretion from the airway. By doing this, we are working on child's mechanism which reduce the work of breathing, improving the delivery of mechanical ventilation, improving gaseous exchange, preventing and resolving the respiratory complications, facilitating early weaning from the ventilator. These are the very short-term goals. And long-term, as a physiotherapist, we are more focused to prevent the postural deformity, improve exercise tolerance, and return to the maximum optimal function. Now, what are the indications because of what problem child can get admitted in the ICU or NICU? It can be a bronchopneumonia, bronchiectasis, bronchitis, cystic fibrosis, atelectasis, sepsis, respiratory distress syndrome, asthma, intubated child, post-extubation, cerebral palsy child, post-surgical child. This is a very common indication just because of what child have to admit in NICU or PICU, and our role gets started from this point of view. Rather than this, Guillain-Barré syndrome, encephalitis, and meningitis are very common causes because of what child have to admit. Now, after indications, these are the very minimal or very highlighted contraindication in which postural drainage or chest physiotherapy can be little complicated. As a physiotherapist or aware physiotherapist, we must know all these terms. Very premature infant, because in very premature infant, your postural drainage or chest PT can be very unpleasant sensation or experience. Very sick, unstable infant, low platelet count patient, recent ischemic chronic hemorrhage, internal chronic hemorrhage, pulmonary hemorrhage, gastroesophageal reflux, any cardiac insufficiency or instability, pneumothorax, recent tracheoesophageal fistula repair, abdominal distension, pulmonary hypertension, and pulmonary edema are the contraindicated things for performing chest physiotherapy. Now, before I would like to start with this, I would like to say at the end, definitely we will focus why, as a physiotherapist, our role are most important at the time of NICU and PICU. In the end, definitely we will have some question answer session, and we will see some examples also. So be attentive over these lectures. Now, pediatric chest physiotherapy consists of postural drainage, percussion, vibration, breathing exercise, of stimulation techniques, and airway clearance and suctioning. Before we proceed further, these are some basic difference in the anatomy of pediatric patient and the adult patients. In the pediatric patients, the ribs lies more horizontally in compare with adult patients. So we have to keep this in our mind. The thoracic cage are more flexible rather than rigid. Underdeveloped intercostal muscles and head size is also one of the considering factor to perform chest physiotherapy for the patient comes under the NICU and PICU. The equipments what we people are using to perform our procedure are suction catheter, connecting tubes, suction resource, oxygen resource, clean gloves, PPE kit, stethoscope, manual ventilation bag, or mask or ambu bag. Now, pre-procedure assessment and monitoring. Now, from here onwards, our lecture goes more practically, or as a therapist, what we need to understand. See, we first and foremost need to assess the patient's lung. by assessing patient's lung, even if you assess by standing in the side or with the help of stethoscope, you will come to know at what level, what kind of obstruction or what kind of problem child is facing. If you know your assessment properly, definitely you can work better to have better prognosis. So for the child, you have to listen about these three voices. One is whistling, crackles, unequal aeration. If child is having any kind of this out of any three voices during inspiration, you can understand the child is suffering from the upper airway obstruction. Or if child is suffering from the lower airway obstruction, you can have this kind of voice during expiration. So by just observing inspiration, expiration voice pattern, you will come to know from where area you have to start your postural drainage or suctioning pattern. Now, by the help of stethoscope, when you start auscultation, this is called the Z method, which will help you to locate the area of secretion accumulation so that you will start with a postural drainage pattern. As we all are aware, in this second wave of pandemic or COVID, children are also getting affected. So again, this lecture or this session or NICU, PICU physiotherapy maintenance will really helpful for the people who are in need of extremely good care. And as our role are essential and vital during this situation is going on. So this is Z method. Starting from the right side of the upper lobe, same on the left side, then in the middle lobe. It gets repeated on the right side middle lobe, then lower lobe, and on the left side of the lower lobe. These are the 6 points where we have to check for any kind of secretion, or we can compare the sounds which are coming over there. Now, quality of breath itself says so many things. What kind of secretion it is, at what amount secretion can be over there, and what kind of child is suffering from which kind of problem. Like it's an infected kind of secretion, or it's just a airway blockage. By sound, we can come to know so many things. If it is clear sound, you can have this kind of voice. In the chorus, when there is a secretion, by the help of stethoscope, you will able to hear this kind of sound. When your trachea and the entire pathway is clear, you will have a sound like a vessel's kind of sound. You pass the air during any vessel or any pipe, the resonating sound will come. When you are having secretion, the resonating sound will reduce with the resonance, and you will have obstruction kind of reflection over there. When there is no voice or very less voice, you can say it is a lack of the air movement. It shows the clearly there can be a pneumothorax, or it can be just a blockage or heavy blockage in the airway. Now, listening without stethoscope also help you out. Over here, we will come to know that congestion, cough, and stride kind of voice over there. If congestion is there, you will have this kind of sound. This is just the upper airway congestion. If child have cough, it can be wet, dry, or barky. It can suggest the infection kind of cause over there. The sound will be like this. And if child is suffering from high pitch inspiration, upper way obstruction can be heard like this. Okay, so again, I would like to repeat myself. Before treating child, you must know your assessment thoroughly and output of your assessment. So by knowing all these sounds, knowing all this method, you will able to locate the area of work on your child's lung area, so that you will have better prognosis and output. So go through it very well. Now, assess patient situation to place in a different position. Before and after procedure, you place the patient in such a position so that the gravity will definitely help to get secretion out of the lung. In that manner, you have to take care of the lines, electric wires over there, tubes, IV, position depending oxygen level, and one most important thing which actually so many people are having lacking hands on it, that is pain. Because if neonate or pediatric patient are there, they are not able to speak, so they cannot express or they cannot show how they are feeling or how much pain they are having. So that for that you can definitely use the modified premature infant pain profile score, which will definitely tell you how much child is suffering or what kind of pain he or she is having. Also takes the baseline vitals before starting with your procedure. So this is the pre-checkup for your child. As you are able to see in this screen, the green line shows the heart rate, yellow one is showing the saturation of the oxygen and the pulse rate over there. In the red line, it's the arterial blood pressure, and the last white is the respiratory rate. You must know the normal vital values so that you will definitely try your best to get your patient on a normal range. So these are the normal range typically for the infant and the children up to the age of 12 years. We people are not doing in detail because of the timings, but this is the chart. Basically, temperature is equal for everybody, and for the mainly heart rate, 100 to 160 or 70 to 120 is most considered as a normal in the patient who are admitted in NICU and PICU. So let's get to the next slide now. Again, by observing your child's breathing pattern, you will also come to know how much work you really need to do or how much work child is actually doing or giving extra effort to take a normal breath. On the ventilation machine, you can see this third column, which is showing the ventilation machine graph over there. If normal child is having normal breathing pattern, the graph will go very smoothly. In the second, it's a bradycardia. It means breaths per minute below than the normal. In that particular part, your diagram will show larger wavelength compared with a normal size. In tachycardia, breaths per minute is above than normal. This condition shows child have to take so many breaths to fulfill his oxygen demand. In this case, wavelength will reduce compared with a normal one. Then it's a Kenny's strokes, deep, then shallow respiration followed by the apnea. In this situation, sometimes you might feel the child is not having any breath. But in this situation, child will have a breath, then they will have a gap, again they will have a breath. So this last three are much more, or it is more complicated kind of things. So whenever you are treating your patient, take care what kind of breath your patient is already taking before your procedure, and make sure after your procedure, child will have to go up to the near normal range. Fifth one is Kumskin. In this, fast, deep, labored respiration without pauses. So this is one of the most typical method of what we see in NICU. Child is suffering because of any kind of abnormality, and if he is admitted over there, child have to work excessively hard to have a breath. In this condition, so many times child muscle get fatigued, and child need to keep on a ventilator machine to give him a rest for the ventilation effort. Last one is Byers. It's an irregular breathing pattern with a period of apnea. Again, this is one of the very difficult kind of breathing pattern which we need to solve it during our therapy and our procedure timing. Okay, now let's move towards the main procedure. As you all are aware about the postural drainage, we will go quickly through this and we'll go. Okay, now procedure is a postural drainage. Position for the gravity to help mobilize the secretion. Percussion, vibration. If patient not tolerate the position, make modification, keep in a flat or elevated position. See, in the adults, we can definitely place them in such a position where they are able to tolerate the position somehow if we need. But in the neonates, it's not possible all the time that we will follow the idealized position. So if our need is so, we can modify the position depending on patient's condition and patient's stabilization of the vitals. Now, as you are able to see in the frame, there are two cups. They are called the percussion cups. In the neonate, our hand are such a large, sometimes child is not able to get proper percussion or vibration or resonance over there. So we will use this percussion cup to give the proper resonating effect on child's chest. Now, what is percussion? It's a painless rhythmic clapping with a cupped hand on each and every area. 1 to 2 minute percussion is mandatory or it is needed over there. percussion is followed by the vibration pattern. It is a sustained downward vibrating motion with flat palm of the hand, only performed when patient is expirating. It helps to mobilize secretion. Now, shaking and vibration. Most of the time, what happens when neonates are admitted, they only or very well respond with the help of the shaking and vibration because they are very much sensitive. So, chest wall are so when we give them percussion and vibration, automatically they start secreting so many secretions out of the lungs, and they will definitely, it will help them to breathe normally. Now, there are also some risk factors related with percussion and vibration because of each and every therapist has a different kind of power in their wrist hand. So you have to take precautions while performing this, or it's a precautionary use. The child is not suffering from the rickets. If if there is any skin damage or presence of any chest drainage, if there is a thoracic incision or bronchospasm, in this condition we should avoid the percussion and only focus for the different methods like suctioning. Now, procedure for the postural drainage. Mainly in the neonates, we will focus on the 6 components: anterior segment of the upper lobe, posterior segment of the upper lobe, anterior middle lung on the right side, anterior base of the lower lobe, lateral base of the lower lobe, and posterior base of the lower lobe. These videos are only for the demonstration. So what you are seeing in this is a normal patient. We people are going to proceed for the percussion and the vibration. Right side upper lobe. This is the percussion and followed by the vibration. To save time, I am running 2 videos at a single time. Lateral side of the lobe. It's a middle lobe. Now, just to demonstrate what are the exact sites or position for the child to start with percussion and vibration. This is the anterior segment of the upper lobe. This is the posterior segment of the upper lobe. This site is for the anterior middle lung. This side is for the anterior base of the lower lung. Lateral base of the lower lobe. Posterior base of the lower lobes, left and right. Now, during procedure, definitely you need to monitor all the vitals, oxygenation, positioning and tolerance, percussion and vibration intolerance for the patients, how patient is coughing, ability to move secretion, and patient's comfort. These are the very essential and vital signs you have to look during your procedure so that your child don't suffer from any discomfort or unpleasant sensation. Now, after postural drainage, this is one of the most important part, suctioning, but it differs with comparison of the adult patient when we are suctioning. Over here, the maximum range for the suctioning pressure is 80 to 100 mmHg. There are some contraindications and red flags associated when you are suctioning with the neonate. The most important part before starting further suctioning, people are using to having clearance of all the secretions so that our airway will get proper clearance. Mainly it is needed in the patient who are on the ventilation support. Complications which includes hypoxia, arrhythmia, mucus trauma, pneumothorax, increased intracranial pressure, loss of ciliary function, and atelectasis. Make sure when you are suctioning pediatric patient, you must have a proper experience or observation. Even though what happened when actually suctioning neonates, there are the chances that tubes goes a little more inside of the nasopharyngeal area. It can definitely lead to a collapse of the lungs even. So proper measurements and proper signs are needed to cover this. clearance of nasal secretion is very important in the neonates because they are more of the obligatory nose breathers. Nasopharyngeal suction can cause bradycardia and apnea in the neonates. That's why I use the term do it under supervision, otherwise you need a proper experience to treat neonates. Care must be taken with a nasopharyngeal suction in infants with a stridor. As we have seen, the stridor is a one kind of sound. What actually we need to assess high-pitched sound, as this can aggravate the laryngospasm, particularly followed by the exuvation. Suction pressure can be as low as possible so that we can avoid the chances of any kind of damage to the neonate. Now, after suctioning, mobilization and position is one of the most important part to finish your procedure in a proper way. Post-procedure assessment and monitoring. After your suctioning, you must go through the secretion, how it is, what color it is, and how odor it smells. These are the very vital signs. If you know this, you will definitely come to know how much your patient need to have proper postal drainage in the further sessions, what kind of problem your child is suffering from, and how much time it will take to get clear all the secretions. By doing this, you will definitely come to know so that you can have a proper prognosis. Repeat the assessment of lung sound after the procedure and also checks the vital, oxygenation, positioning tolerance, percussion and vibration tolerance, cough, ability to move secretion, and your patient's comfort zone. By checking secretion, these are the classifications. It can be classified in 3 categories depending on the color of secretion, consistency of secretion, and amount of secretion. Color can be divided further in 3 or 4 categories. We people are not going in detail, but still on a round way, it can say it's a white, clear, yellowish, or green. Further, if we want, we can classify yellow and green in a different categories depending on their infection causes. Consistency can be thick and thin. Amount can be small, moderate, and copious. Complication of the postural drainage, oxygen desaturation, pain or injury to the patient's ribs, muscles, spine, vomiting, aspiration of the oral secretion into lungs, increased intracranial pressure, hypertension, bleeding in the lungs. Okay. Now, after doing all the procedure, this is one of the most important thing, documentation. You need to do it. For a safe side and saving the time, I am just going through a demonstration for it. Why your child needs physiotherapy, that considered as an indication of the physiotherapy. As an example, we can consider as a pneumonia, date of procedure, time of procedure, secretion, description, how much amount, what is the color, consistency, odor, then productivity of the cough, patient is able to cough properly or not, we have to mention over here, then vital signs, then what kind of comfort during your procedure patient was feeling. You have to just mention all these things. Now, why as a developmental therapist or a neurodevelopmental therapist, I am interested to take a lecture on an NICU and PICU role of a physiotherapist. That is just because during our practice, if we are seeing 10 new patients in a day, out of 10, there are 7 to 8 patients who give us the history that my child was admitted in NICU, he or she was admitted in PICU. So sometimes we thought, how many patients are there for the NICU, PICU, they are coming to our OPD. So if as a physiotherapist, we play our essential role, or if we people are working in association with neonatologists or ICU care giver professionals, definitely we will identify the developmental disabilities. We will definitely ask this patient to go for the early intervention so that we can further prevent the developing disabilities. So the main summary of today's lecture is, if we know our role in the ICU and PICU, we will definitely help child to get cure faster, to prevent any developing disability, to make family understand about their child's condition, to start with the early intervention, to make prevention is better than cure. In the NICU and PICU, this kind of skills we people can use Alberta infant motor skills, the infant motor performance test, Harris infant neuromotor test. By performing all different tests, we will come to know if this child who is admitted in NICU and PICU are suffering from any kind of motor or sensory loss, yes or no. If patient is suffering from any kind of motor neurodevelopmental loss, we can counsel their family, we can make their child under observation, and as soon as possible or when child's medical condition permits, we will start with early intervention so that child's time will not be wasted and child will have better prognosis and outcome, and the life will be more comfortable for this child and the family. So these are the main important part as a physio we need to know before starting our practice. Hello.
Yes, sir. Are you there, sir?
Hello.
Yes, sir.
Am I visible, ma'am? Is it visible?
Yes, sir.
Okay. So after finishing this talk, let's go through some cases so that practically we can relate our talk with the cases over here. As we have mentioned in indication and contraindication, I hope you people are aware of indications and contraindication. If you know it, you can give better answer of these questions. In the case example 1, there is a one child with a hemodynamically unstable with a isolated right upper lobe collapse and hypoxia. Is physiotherapy is needed for this child? Yes or no? That is the question. Over here, I don't know, we can take a question or answer, but at least you people, all who are listening, are aware and you can give answer to yourself even. Let's go further. The answer of this patient is no. We cannot give chest physiotherapist to this patient because, as we have seen in contraindication, hemodynamically unstable condition is not good for the chest physiotherapy. So this kind of patient, we should avoid the chest physiotherapy. Only what we can do is giving proper positioning. We can give passive movements, splinting, so that child will not suffer from any contracture in the future. With the same example, we will definitely take if child is having hemodynamically instability with collapse of the lung. If child is having only collapse of the lung with significant hypoxia, we can take a risk to give a chest physiotherapy under observation. If child is child don't have any other option, but if child is having proper ventilation by the help of another side of the lung, we can still wait for child's hemodynamic condition to get stable over there. Now let's see the case 2. This is a case of the patient with a low birth weight. Child got birth before 30 weeks and weight was 1 kg. Diagnosis with a sepsis. On examination, patient is intubated, also sedated. Chest physiotherapy shows the right upper lobe atelectasis. In this condition, would you like to give a chest physiotherapy? Yes or no? As we are aware, atelectasis is the indicated condition, so that we need to give chest physiotherapy to this child. He will definitely respond better with chest physiotherapy. Again, after finishing chest physiotherapy, you will definitely give postural drainage method and manual inflation bag and keep patient's right side on up. Now, case 3, neonate with pulmonary hypertension. Pulmonary hypertension, as you are all are aware, this is a contraindication condition. So, in this condition, we cannot give chest physiotherapy because there is a risk of sudden cardiac arrest. But if child is not having proper ventilation or he doesn't respond to ventilation mechanism, with the observation, you can try for the upper respiratory tract obstruction removal with the help of suctioning. If you treat this patient, take proper precaution with the chest physiotherapy, postural drainage, percussion, vibration, and compression. Monitoring throughout the session is very much essential in this case. At the end, I would like to say our happiness will and must be measured in the happiness of welfare of our children. This is a quote by the Nelson Mandela. As a pediatric neurophysiotherapist, I would like to say this is the area of excellence by the physiotherapist must to understand. If any child is in NICU or PICU, definitely we will rule out his or her motor developmental disabilities so that in the clinical trials we will definitely have better prognosis. So play a role, essential and vital, understand the importance of it, and all the very best for your future and all your practice. Thank you so much.
Thank you so much, sir.
Thank you so much for.
I hope everyone has enjoyed and they have learned something from the webinar. Thank you so much for your insight knowledge. Thank you, sir.
Thank you so much, ma'am. Thank you.
Thank you, Arth sir.
Thank you, Gaurav sir. Thank you so much for inviting me here. Wish you all the very best with all of your academic career, sir. Thank you.
Yeah, thank you. Thank you.
Thank you, sir.
We'll see you soon. Thank you.
See you, sir.